So, good afternoon everyone. My name is John Engler and I'm the CEO of Shelter New South Wales and the Chair of National Shelter. It's my absolute pleasure this afternoon to be welcoming you to this session, Improving Health Outcomes Through Quality Housing. I'd like to start, of course, by acknowledging that we're meeting on the land of the Wurundjeri people of the Kulin Nation, and I certainly would like to extend my respects to elders past, present and emerging. And as we like to do at National Shelter, always say this land never was ceded, always was and always will be Aboriginal. This afternoon we'll be hearing from three speakers in particular, and I'll be asking some questions on behalf of you here in the audience and also anyone who's watching remotely. So first of all, we'll have Professor Emma Baker, well known to many people, from the University of Adelaide. We've also got Dr. Kate Hunter from the George Institute of Global Health and from the University of New South Wales, and Chris Turner, who's from CoHealth. So I might start by inviting all three of our speakers to come up onto the stage, and we'll start. Really encourage people to ask questions. We've had a number of sessions today where the speakers have really had to think quickly on their feet and think passionately, I suppose, about what's really important through questions given to them from the floor. So I encourage you to do that today. Thank you. We will start with Emma. So I'm just sure if you've got the presentation, haven't you? So I'll bring Emma up here if you're happy to do it from here or from the seat, whatever works for you.
Does this look like a COVID waiting room? And the other topical thing I thought was while I was waiting, it actually smells a little bit like mould, which is topical for what I'm going to talk about today. Anyway, so what I'm going to talk to you today about is a little bit about the connection between housing and health, a little bit about what we know and what we don't know, and how we might develop better data to know it better. So I come here with many hats, and some of them are housing and some of them are health, but I run in Adelaide the Australian Centre for Housing Research, where we're focused on really trying to drive evidence on the relationship between housing and health, but also other things. And I'm Deputy Director of the NHC22 Centre of Research Excellence for Healthy Housing. So if anyone wants to talk healthy housing after, yell out. So, thank you. So I've put this slide up just to give you a bit of a conceptual view of the way that we think about the housing and health evidence base. And basically what I would say is we've got an evidence base on housing and health, but it's a great big collection of bits and pieces. So when you look at that slide, a couple of things should stand out. It's a collection of what people have been able to measure, what people have wanted to measure, and what people have managed to get funding to measure. So there's a lot of missing stuff in the types of evidence that we tend to base policy on. It's also a pretty biased evidence base, for those reasons. And the other thing is, you notice in that slide, it tends to be one thing connected to the other, and that's something about the measurement. It's, the simple things are in the evidence base, but really, things are much more connected together. All right. Oh. Sorry, that's interesting. Here we go. Okay, so I just thought before we even start with evidence, one of the things might be to kind of talk a little bit about kind of the way that we conceptualise housing. So remembering that slide being a whole collection of bidirectional things, actually what we're learning increasingly is housing and health are bundles. So every individual one of us has a completely different bundle of housing and a completely different bundle of health. So you can then begin to understand why it's impossible, to make decisions that are general. The other thing I want to say is that we regard housing affordability as what we call an apex driver of health. So housing affordability might not drive health directly, but in Australia at least, the housing that you're able to afford then can drive health outcomes. So housing affordability is really, really important as something to look at when we're thinking about housing and health. The next thing to say is, and it's not surprising to anyone, health effects are highly dependent on initial health. And so it also means that the people with the worst health tend to have the worst housing, that then gives them the worst health, that then gives them the worst housing, and it goes on and on and on. So some of the slides I'll show you in a minute show you these beautiful gradients. They're not beautiful, they're terrible gradients, with poor health being related to poor housing conditions. The other thing to say is that there's a really clear pattern of unhealthy housing in Australia. There are distinct groups who are particularly vulnerable to poor housing outcomes that drive their health. And there's also a geography. So urban areas tend to have more unhealthy housing, and there's a lot of work going on at the moment to understand that. And the final thing I want to say is that housing conditions, which is the topic of this talk, are often completely overlooked. Sometimes it's because it's difficult to measure. Sometimes it's because it's just too much to kind of get into a simple research brief for a government department. And much of the evidence is flaky, and I've used this example a few times, but sometimes when you look at policy and you go back looking for the evidence that was based on, and you end up getting back and finding it was based on 5 women in Glasgow in 1956. So we take evidence, we treat it as truth, and then we move on, but sometimes we need to look backwards and kind of question it. So we've been really interested over the last few years in trying to kind of improve the value or the quality of the evidence based on which decisions are being made. So in the second part of the talk, I want to talk about some things that we do know from the data that we've collected and how we might know them better. Really, this talk comes, or a lot of this work comes from a realisation a few years ago that the last time the Australian Bureau of Statistics did a national housing conditions survey, a nationally representative big data set that collects, what's behind the front doors of Australian households, was 1999. So some of the data that I'll talk about today is from a big collaborative project which is designed to collect some data so that we can all kind of sing from the same song sheet and start using kind of combined data sets. So the first 3 are complete, and all 3 publicly accessible, so you can access them through the Australian Data Archive. But the first one looked at 4,500 Australian households and tried to find out what conditions were like, who was living there, what their aspirations were. And the thing that really stood out from that was the big story that we're always missing is the story of renters. And so the next survey was much bigger, so it went across the whole of Australia, 15,000 renting households, and it collected all of that information from them. And then the third really emerged as an opportunistic project, but it's probably been the most impactful. It was to ask tenants to send in photos of their houses, because when policymakers talk about it, they can never flash a picture and make people understand what they're talking about. So, we just make this accessible. Anyone can download those pictures and use them in their reports. Oh, I should say, the final one is the Australian Housing Monitor, which is, and there's some of my colleagues in the room as well, which is the exciting one. So we've now been funded by the Australian Government to go and do this in a monitor form in multiple years and expand it to the whole housing population and about 25,000 households. So look out for that one. Okay. When I was thinking about this talk, I thought, well, okay, what are the actual priorities? If you can only hit at a few things to improve, what are the priorities that we should be looking at? I think there's 3. One is healthy temperature, which, might be surprising to some people. By healthy temperature, I mean houses that are warm enough. And this really emerged from a piece of research done and published in The Lancet a few years ago, which was striking to all of us. It said that you're much more likely to die or be sick from your housing conditions in Australia than in Sweden. So Australian houses were cold, and then we had the double bunger of being in a nation that refused to believe that Australian houses were cold, so we keep building them. Anyway, so I'll talk a bit about healthy temperature. I think general quality and condition, and then something overlapping the two, I think the rental sector in general, which spans both of them, but I think that tends to be where a lot of these things are coming out. Okay, so this is a bit. These are a few graphs on the topic of temperature. When we first read that article, we were like, that's impossible. You know, we only talk about heat waves in Australia. So we went and quickly mapped, and it doesn't come out very well on the graph, but we quickly mapped excess mortality by temperature. And that is the kind of the top right one. But basically it shows all the excess mortality happens directly in the winter months, and summer's fine. So we thought, well, let's go into that and have a bit of a look. So we sent sensors out to a series of houses and monitored their temperature over winter. We did it in South Australia, and the graph on the left-hand side shows you the results. So basically, during winter, none of the houses in our sample ever got to World Health Organization healthy temperature. So we're expanding that study now and collecting a lot more data. But just to give you a view of what it's like in the rental sector at the moment, I've just pulled up a graph which shows you people who are able to keep warm in winter or unable to keep warm in winter by their health, self-assessed health. And so straight away you see this gradient which shows you, people with excellent health tend to be in warm houses. People with very poor health are highly likely to be in very cold houses. So the second one is quality and conditions, and there's some photos from that repository that I was just telling you about. But it's really hard to know, or has been really hard to know, how many Australian households are basically unhealthy to the point where, the housing is harming the health. So our working estimate, based on initially Hilda data, was that 1.1 million Australians are living in housing that is actively harming their health. When we went and had a look at some of that data in the first national study, we ended up with about 12% of dwellings. And then, interestingly, when we hit the rental data set that was just recently produced, we have 23% of rental dwellings which are classified as poor or very poor. So it's likely that a quarter of our rental dwellings are further than not helping people's health, they're actually actively harming people's health. So I suppose I just wanted to end with some kind of maybe hopefully positive things. Challenges and opportunities, largely opportunities. I think, COVID-19, and some of you heard me go on about this morning, COVID-19 has made good housing more of a shared problem. So I think, things are better for people's housing, and they're hopefully going to get better from here. The second is the fact that renting is becoming mainstream now. So the last census was collected. The previous one showed renting just edging up in terms of the proportion of the population. It's now probably, we think, when the data gets published, just kicked over to be a bigger tenure type than outright home ownership. So that means that lots of people are renting, and from broad backgrounds. Some people are renting for life, and that probably does a lot to improve the conditions in the rental sector or improve the pressure to do it. The third thing is, just to kind of alert you, the World Health Organization did this really fantastic series of guidelines on healthy housing, and what it did was it gives governments something to kind of hitch their wagons to. So, it says, housing temperature should be within 18 and 24 degrees. So we know when we're not doing very well. And I think a lot of countries around the world have taken those, and that's created a bit of a movement to really look at the conditions and the quality and the healthiness of people's houses. And I just want to end on my usual tale, is that we actually, wouldn't it be great if we actually had the data and weren't just piecing together bits and pieces? The bigger, the more shared data that we've got to work from, the better we're going to be able to tell the story.
Thank you very much, Emma. We might roll through the presentation, so we'll now hear from Dr. Kate Hunter, and then we'll save our questions for the end, and very much looking for an interactive panel between Kate, Emma and Chris. So welcome to Kate.
Thank you very much. I too would like to start by acknowledging the traditional owners of the land upon which we meet, and I might have to use this clicker instead. Advice. Which button? Sorry.
I think you. Oh yeah, that one. Sorry.
I did. That's what I pressed. So I would like to start by acknowledging the traditional owners of the lands upon which we meet, and as well as the lands upon which this work that I'm about to talk to you about was produced. And for us, that was on the lands of the Bidjigal and Dharawal people. And here, of course, we're on the lands of the Wurundjeri people of the Kulin Nation. So I pay respects to elders past, present and emerging, and acknowledge any Aboriginal and Torres Strait Islander people present in the room today, or of course online. So, any work that, as I am a researcher and I'm a health researcher, any work that we do, it's not solo, it is with a team, and I'm only one of many, and this is the list of the people who work on the Healthy Housing Project, and we are, while we're a large team, we're a small project, but a very important one for the local community. So, first and foremost, I do want to acknowledge my peers and my colleagues, and certainly acknowledge that half of, I think the majority of us are Aboriginal and Torres Strait Islander researchers, clinicians, community workers, as well as non-Aboriginal healthcare workers and researchers. So what I'm going to do today is while we've heard from Emma, which was the broad scale, I'm bringing it right down to a project and very much at the coalface. And so I'll be positioning housing and health as to how I position it. And then just talk very briefly also about how we're positioning the concept of health, and then talk specifically about our project within housing and social prescribing. So, first and foremost, we're starting from the point where housing is and health are both human rights. We have the UN Declaration of Human Rights that you all are very familiar with, and you know that everyone has the right to a standard of living adequate for the health and well-being of themselves and their family, and this includes housing. There are also the SDGs, the Sustainable Development Goals, that cut across housing as well. So, for example, we have for SDG 11.1, ensuring access for all to adequate, safe and affordable housing and basic services. There's also the need to strengthen efforts to protect and safeguard the world's cultural and natural heritage, and place is of critical importance. And then there's 11.7, where the SDGs talk about the need to provide universal access to safe, inclusive and accessible green and public spaces, particularly for women, children, older people, persons with disabilities. And it is from within that housing fits. There's also, within the UN Declaration of Human Rights, a number of key elements within the rights that do cut across housing yet again, and it is the right to family life and privacy, the right to freedom of movement, assembly and association, the right to health, the right to development. So, from our perspective, we're seeing health and housing as totally connected and very much a human right. And it's then understanding, when we're looking about health, what are we thinking about? And this, we're very much taking health as from within an Aboriginal paradigm of health and healing. And this work is being produced from our program, our Aboriginal and Torres Strait Islander Health Program. And understanding the concept of health is, as has been described by NACCHO, the National Aboriginal Community Controlled Health Organisation, that Aboriginal health is not just the physical wellbeing of an individual, but it refers to the social, emotional and cultural wellbeing of the whole community. And it is in which each individual is able to achieve their full potential as human beings and thereby bringing about total wellbeing of their community. And once again, when we're talking about place-based and housing and the concept of what that means, this is critically important to understand from which people are coming when they're talking about housing experiences. So within that housing and social prescribing project, as you might have heard in an earlier session just gone, that our colleagues Anya Andhurst and Lola Ryan spoke about some of the experiences within that project, and I could talk a little bit about that in a minute. But it came about from a community child health forum where it was really a number of services really getting together and just having a yarn about keeping kids safe in the home and what are the factors that influence that, and housing came out resoundingly high as one of the issues, and there was shared frustration amongst the health workers, Aboriginal education officers, as well as the doctors who were present. And all of them shared this frustration in saying we can see the health impacts that poor housing is having on families, on clients, on community, and yet as advocates we really don't know where to turn and how to go about it. So from there we all got together and really just have this shared idea of trying to unravel that system a little bit. And part of that is really understanding who's doing what, how we can work with each other to reduce some of the efficiencies that are within systems, and we know so many checks and balances are necessary, but they also have to be safe and equitable as well. So it's really working out how we can develop a housing screening tool and referral pathway that is equitable and safe for people to go through. And importantly, the whole project has a very strong governance structure. Underpinning it, we have an Aboriginal reference group as well as the larger project group, which really is everyone, and then of course we have a small operational group just working on the everyday parts of the project. And what we're aiming to do, as I've mentioned, is identifying and developing a housing screening tool that health workers and service providers, community service providers can implement. And of course we wanted to know what sort of things are already being used by health service providers, and so we did look to the literature. We also spoke to more than 50 stakeholders working across health really, as well as housing. And from those interviews that you heard a component of that lived experience that can be incredibly traumatic. Just earlier today, but the rest of the interviews really spoke about the processes and where the wins are in how to achieve favourable outcomes for clients. The whole project, we recognise that we're working within a system that is resource poor, where the housing, the current funds available for ongoing and proactive maintenance that's been recognised throughout this conference are not adequate for the need. And so we recognise the true limitations of this project, and we certainly don't try to change that, but what we do try to change is that interaction and how those services do communicate. And so we spoke to the stakeholders, and we also looked to the literature, as all health researchers tend to do. And we looked to see, okay, who is doing social prescribing and not only for housing but also for broader social determinants of health. And when we're talking about social prescribing, it's really the health service providers understanding the needs of their client and the complex needs of their clients and connecting them with the right services, particularly that relate to the social determinants of health. So within that, we identified about 48 papers, and from that, really there was surprisingly not a lot of validated tools that health providers have been using. What we did, we then pulled out a number of those questions to see what are those common elements that people are looking at and asking about, and also what are the referral pathways that people have been using, both in Australia as well as in other countries. And there's work, as people have alluded to, that's been going on in New Zealand and certainly Canada and the US. So we developed, working within the team, we gathered all this information, brought the team back and said, okay, this is what we have, so how are we going to develop this housing and screening tool that's going to be appropriate for the health providers to trial and use? And so we really have developed quite a simple one that looks at, it's divided into 3 sections, where we have a section that asks very broad questions about housing, and where we talk to the physical and structural issues. We consider what are the social factors that are affecting your housing experience and your health, access and mobility, the affordability, what are any issues as far as affordability are concerned. For each of those, we look at what are the other information that really delves into how is this then impacting health. And as health service providers, they know what the risk factors are, for example, for asthma. They know what the risk factors are for other injuries. So it's quite an easy next stage for the health provider to really nut out what have been those health issues that have been caused by housing. And then through going through the information that's available online, and this is based in New South Wales, so the Department of Community and Justice, looking at their forms, what is the information that they need, so that there's not this going back to the service provider, the health provider, saying, actually, I needed this information in the letter, or I need a bit more information. So we're trying to pull it all together to really help the system be a little bit more efficient, and to release a lot of the pressure that's on so many of the clients just trying to navigate the system. We also developed a letter template for the health provider to use, and that consists of 5 main areas. The first is looking at the patient-client information, just getting those details right, understanding, of course, if there's been a caseworker involved, really being very clear about the housing and health impacts of those, providing the evidence for it, referring to guidelines. Okay, what is the evidence of what should be the appropriate and what is expected to be? What are the standards that people should be meeting? And then calling for the action, asking for timelines that are specific, that relate also to the provider's own policies. So really saying, we understand these are your policies, so by that, these are the timelines that we're expecting impact to occur, and then having also an escalation plan as needed. So essentially the pathway is applying the tool to identify what are the housing issues. And I have to say, one of the things that so often we talk about when we're in health and housing, unfortunately, is when things go badly, go wrong. And so it gives that lopsided perspective of the relationship between health and housing. Whereas if we were all to be taking a wellbeing approach to so many things, we would be able to see a much more positive alignment. But that's for another conversation, I suspect. So looking at the screening tool, we then develop the letter, and depending on the result of the letter and the information and whether or not the person has a case manager, we either refer the person to the case manager or connect them. So that is really the essence, and we're trying to keep it as straightforward and simple and realistic for the health service providers and community workers to apply, because we do know how time-strapped everyone is. But we also know how much time people are spending in housing-related issues. So if we can sort of bring that time down to really be directly supporting families, then that'd be fantastic. So we're at that stage where we're ready to really finesse the tool and to trial it locally and see how that's going, and tweak it so that we're sure that the tool itself, importantly, is acceptable for clients and families, and then has that impact and effect that we're hoping simply in navigating the system. So our next steps, because this whole project is really centred with and focused to ensure benefit to Aboriginal and Torres Strait Islander people, our next steps will be very much guided by our Aboriginal and Torres Strait Islander reference group members, just identifying, okay, so what do we want to be able to do with this tool if it is effective? How would you like to trial it, implement it, put it into real world practice? I think I might leave it there. Look forward to speaking more about this whole issue, and of course acknowledge the broader partners with whom we work, and the artists and some of the references that I alluded to earlier. Thank you.
Thanks, Kate. No doubt there'll be lots of questions that come from that. I've certainly got a number myself. Thank you, great stuff. We'll now hear from Chris Turner from CoHealth, and no doubt again we'll listen to your presentation and save the questions till the end for all three.
Yeah, thank you. And I must admit, this is probably the first time in 3 years that I'm at no risk of my two daughters, Stevie and Tabitha, interrupting me as I present. So it's actually quite nice. In making my acknowledgement to the traditional custodians of the land, I'd also like to pay my respects, but acknowledge the strength, pride and resilience of Aboriginal and Torres Strait Islander peoples. So we've heard some great perspectives from academic and research, and what I'd hope to bring today from the organisation I work for is some practice perspectives. So I don't have a lot of, well, actually I only have one slide, which is just me. And what I'm really hoping to do is just give some practical examples of that intersection between health and housing. So the organisation I work for is CoHealth. We're a community health organisation based here in Melbourne, and we work in the health and social care sectors. Our vision really is to impact health inequality, and we look at that both from a determinants perspective, and we also look at that from a delivery perspective. So we look at where in the upstream space we can tackle the things that lead to poorer health outcomes for certain communities. And in the delivery space, we work both in a primary prevention but also a secondary delivery perspective. And for a lot of the communities that we work with, as has already been referenced by my co-panellists, is that the word housing, the word accommodation means so many different things. It can mean private, it can mean public, it can mean social, it can mean affordable. For some folks, it can mean a caravan park. For others, it can mean a car. Places and spaces come into this conversation as much as it does built form. So one of the first examples I wanted to provide was in the context of keeping safe through COVID. We've done an enormous amount of work during COVID in working in what the government has labelled high-risk accommodation settings. So we were called upon not last year, it's 2 years ago now, called upon to be one of the responders to provide medical support at the hard lockdown that was experienced by residents here in Melbourne. Now, that hard lockdown was called upon not because there was any necessarily behavioural concerns or person concerns. It was the environmental concerns associated with the accommodation setting that those folks lived in. A lot of the public high-rise towers have shared amenity. They have a lot of high touch points where there was a greater transmission risk of COVID. And so no fault of the individuals that lived in those accommodation settings, they found themselves in a hard lockdown while the rest of Victoria didn't. And with the community, what we've worked on, and we've moved from just public high-rise into other high-risk accommodation settings, so rooming houses, social and affordable housing settings, high-risk sort of more aged care, non-federal funded aged care facilities, so potentially those where folks might have mental health concerns or be supported by the state to live in supported accommodation. And what we've learned from that is that the design of those facilities is what created the risk for people. The design of the facilities in the way that their amenity was distributed, the fact that individuals couldn't leave their apartment without coming into contact with other people, even the idea of having groceries dropped off in a lobby and everyone congregating in the lobby, all of these things contributed to increased infection risk for those individuals. And that's not unique to the context of COVID. Put any other infectious disease into the mix, influenza, gastro. There is the opportunity in these accommodation settings, by the way that they're built, for a higher risk of poorer health outcomes for those communities, even before we start to think about some of the social determinants things which are also in public housing a huge concern as well. Emma mentioned keeping warm. On the other spectrum, there's also the heat impact, so the health impact of heat. So we know for a lot of the communities that we serve that there are two things that influence temperature regulation in their homes. There's the built form of the home itself, and then from a determinants perspective, there's the person's ability to fund heating and cooling. So for a lot of our communities, whilst the built form itself may not be suitable, even where there is the ability to regulate temperature, a person's ability to pay for gas, pay for electricity, to feel comfortable to use that infrastructure comes into play as well. And with the climate shifting in the way that it is, we do see and we do know that climate change is going to be one of the greatest health emergencies coming. We know that the resilience of our communities to heat is low. We know there are heat island effects in a lot of communities as well. We know that individuals who live in hot boxes may not have anywhere else that they can go to. And we do know that there's a need to invest not just in homes, but into public and civic infrastructure in a way as well that gives people opportunity to find relief when there isn't the relief in the accommodation that they live in themselves. The other thing I kind of mentioned was the interaction between housing and the social determinants of health. So we see this a lot with communities where there might be large families living in small apartments. There might be cramped living conditions such as rooming houses or shared houses. And I'm not speaking necessarily to social or affordable housing here. This could be a share house for university students where you've got 8 people living in a 4-bedroom home. All of these things can contribute in a lot of ways to other determinants not being met for people and therefore leading to poor health outcomes. So think about accommodation setting where you have a lack of storage space. So a lack of storage space might influence the way in which you shop. You might not have the ability to fit a fridge, so you rely upon utilising more processed foods instead of fresh foods. You might have small amounts of storage space, so you need to shop more frequently. Shopping becomes a burden, therefore it happens less often. So you rely upon buying food in as opposed to making it yourself. All of these things about the built form have the consequence of changing an individual's health behaviours. And it's not necessarily due to their own choice, but rather the way in which the environment is forcing that choice upon that individual. So that might lead to that individual having poorer nutrition leading to tooth decay then leading to a lack of confidence, a future kind of concern for anxiety and mental health. But equally, actually, for employment, one of the biggest things that people need is teeth, because a lot of people without teeth don't feel confident to put themselves out there in the community in a way that seems them gainfully employed. So whilst these are not necessarily causal and academic links that I'm presenting to you, what they are is correlations that we see in our practice between the way that a accommodation setting can have impact on a person's health and well-being over time. Other things about the share houses, for instance. Young university students might live in a share house setting because it's more affordable for them, but we mentioned affordability earlier and the impact that that has on people. If you're giving a certain amount of your money to accommodation, what are you foregoing? So for young people, that might be that they're not able to afford, they don't have cash available to afford food. For a lot of young women we see, they actually forego the purchase of hygiene products. We also understand that they don't pay for medication or they can't afford to pay for transport. Again, what are the impacts that might have on their health over time? For instance, not having adequate access to hygiene products can lead to infections, which can lead to an infection which might lead to either a terminal or at least a short-term adverse health outcome for an individual. Not having access to pay for transport might see a person not able to engage with university or employment. And again, exactly as Emma said, perpetuating poor housing, poor health, poor housing, poor health over time. It's no surprise to people that obviously in talking about health and housing, that ageing in place is a great concern for us as a nation as well. So as we start to think about the type of accommodation you need as you age, a lot of people immediately look to smaller. So people look at it and go, I'm older, I don't need the size of property I've traditionally lived in. So they look to downsize. But what we're noticing in our practice with aged individuals is that when they downsize, what ultimately happens is that the size of the property to the land increases by going upwards. And if you're older, if you're frail, there are challenges with navigating that split level living. So if you're older and you're frail and you don't feel confident and you continue over time to feel less confident navigating stairs, what is it that's at the top of those stairs that person's then no longer having access to? If their bedroom's downstairs but their kitchen's upstairs, how does that impact their ability to engage in cooking? What does that mean for their nutrition? What does that mean for them over time? If their bathroom's upstairs, what does that mean for their personal hygiene and their ability to engage in personal care and self-care activities? If I can leave you with anything, it's going to be a little analogy about PowerPoints. Most people will have PowerPoints in their house that are at ankle. Now, my thought around PowerPoints is that they shouldn't be at the ankles, they should be at the waist. As you get older, it becomes a lot more difficult to engage with something at your ankles. I can't touch my ankles. And then it does with something at your waist. Now, in health research, it's very common to come across the impact of falls on a person's health outcomes over time. So if you're engaging as an individual with poor mobility in something that's at your ankles rather than at your waist, that's going to increase the likelihood of you experiencing a fall. If you experience a fall and say you break your hip, you find yourself in hospital, going to hospital is one of the leading causes of poorer health outcomes over time. You might find yourself contracting mRNA, or at the moment you might get COVID from the ward. And if you are susceptible to poorer health outcomes because you've got an underlying, your immune system is compromised, or you have heart disease or something, that simple fall may actually result in some really significant health outcomes for you. So again, just thinking about how are buildings useful over the life, not just the useful life of the building, but the life of the individual that occupies them as well. The last area I really want to talk about is mental health. So it's fairly common to come across literature that talks about decent, safe, affordable housing as one of the most important factors for our mental health. And that poor housing or housing that is poor or unaffordable or run down or overcrowded can lead to poor overall health. One of the things that we consider in our practice, in Australia, it's pretty common that your housing scenario comes with some form of contract. Whether you privately own and you have a mortgage, whether you're leasing and you therefore have a rental agreement, whether you're living in public housing or social housing and there are some conditions with which you need to comply with in order to sustain that housing, those contract conditions require you to be able to satisfy them. And so not only am I saying that housing can impact health, but health can also impact your ability to sustain housing as well. So if, for instance, you were to find that you during COVID lost your job. Losing your job might create a sense of depression or anxiety. It also may reduce your income. Now that scenario might lead you to not being able to meet the conditions of whatever contract you're housed under, whether it's your mortgage, whether it's meeting your rental payments, or your anxiety and depression may lead to some other behaviours which are counter to the conditions of your social and affordable housing lease, such as illicit drug use or some form of drug dependency. So again, it comes back to that piece around having good health and having good housing are not independent of one another, and having them both concurrently is actually one of the greatest protective factors for each. And one thing that we recognise is the need for health and housing providers to work more in that partnership. So recently in Victoria, there was a Homeless to Home program funded through Homes Victoria, one of the sponsors of this event. And it recognised that there was a need, particularly for people who were experiencing homelessness during COVID and had been housed in hotels during that period, to be put into more suitable accommodation. In that program, it wasn't just the accommodation that was funded, it was the transition support. So we partnered with Unison and Melbourne City Mission to provide social support, health support and housing support to those individuals as a package, rather than it being seen as someone is seen by a housing provider and now we know they've got a health need, let's bring that person in. Or we're seeing someone as a health provider, we will bring housing support, and then someone finds himself on a really long waiting list and nothing can be done. So the opportunity through the way in which the government funded and financed that program has really given us the chance to demonstrate some really significant outcomes for a cohort of people when you do think about and when you do fund health and housing as interrelated activities, not separate activities. The last thing I just want to leave on is that we're seeking to do more of that as an organisation. So Unison, who I mentioned as one of those partners, we have built a proposal to develop a health and housing hub in Collingwood. CoHealth own a site there, and the plan is for us is to redevelop that into a newly integrated community health centre with housing above, in the hope that we can actually provide some of these models that you will have seen spoken about through this conference, and to start capturing some data which demonstrates in real time the value of integrating that health and housing in a practical sense, and in a lived environment. Thank you.
I'll just now invite each of our speakers to take a microphone, so Emma, Kate and Chris, and we're really going to facilitate a three-way conversation, not only between you as attendees of the conference here and anyone who's put some questions in, and we've got some great ones, but between these three practitioners here. So three very eminent and qualified people here. We've heard about the large experience from Sweden. I mean, that's an extraordinary, when you hear that, it really stops you in your tracks. The stuff that you're working on, Kate, in terms of particular communities, and then Chris bringing in an actual practical example of what does good look like. So I might start with that question. And we normally would do this in a facilitation sense at the end of the session, but I think all three of you have absolutely described, left no stone unturned, talking about the problems that we're faced with. Jumping over to solutions, if each of you just very quickly had one thing you could do tomorrow, a really short-term thing, if you said you've got one go at this, what's the one thing you would do tomorrow that you think in each of your respective areas would make a massive difference? I'll start with you, Emma.
Imagining, is that working? Great. Look, I have thought for a long time that we're missing a trick in Australia when we talk about minimum rental standards. I think a conversation about minimum rental standards is really, really important. But why would we frame it just for rental? If we frame minimum standards in Australia, we capture all of the people that we're worried about. And it puts everyone on a level playing field. So that's probably what I'd suggest.
Excellent, thank you. Kate?
Can I have two?
You can absolutely have two. You well deserve it.
The first one would be to ensure that there is self-determination for Aboriginal and Torres Strait Islander people in any form of housing policy, and true self-determination. That would be the first. Then I think that the second is we can possibly learn from other areas, and I was thinking where we have the issue where housing is the issue, or the quality of housing and the infrastructure, and yet health bears a lot of the cost. And so where are there instances and examples of that sort of thing happening? And I think road safety could be one of those examples where the road toll, in fact, the health system bears those costs. But within road safety, it's our roads and infrastructure that have actually lifted their game in and commitment to safe roads. And I think there's a lot that can be learnt from that process and that platform.
Excellent. Thank you. Chris?
My comment's not all that different. It really focuses on thinking about the outcome we're seeking to achieve and ensuring that the models of practice and the commissioning models are aligned to that, and recognising that that is not one siloed area of government or one siloed area of civic society or public life, but that recognition of the intersection and the opportunity to think about the social and economic value being contributed on all parts of the system, and really trying to think about how we can better integrate responses through a focus on outcomes.
Excellent. All good. All right. Another area I wanted to touch on, and then we'll go to, we've got several questions here at a similar focus, but I'll start with these. Just reflecting on the, I remember somebody, for those of you who don't know, I used to work for St George Community Housing, a big provider in New South Wales, and years ago the CEO, who unfortunately is not with us anymore, she used to say to me, John, housing problems are rarely solved by housing policy alone. Really, rarely. You've got to get that through your head. Start with that premise and you'll do well. So I was really enjoying listening to all three of you basically say that, because I think there is a danger sometimes that we of us who go to this thing and just think everything lives in the housing lane and think that the problems or the solutions live there. I was interested on the idea about the registration. Like, we do register cars, whether they're rented or owned or under a lease agreement. There's a basic standard saying it doesn't matter who owns the car, if it's not roadworthy, so the Kate's point about analogous with roads, you can't use it on the road. Why on earth don't we have that same level of basic certainty when it comes to housing? So any thoughts about, and I'll take your point too there, Emma, about it shouldn't just be this end of the market, but yeah, just a simple system that would make sure, and again, a bit like the road safety, very easy to say, if this was provided as a minimum accreditation or standard of acceptance, these are the benefits that would flow. Any thoughts about a system like that?
Is it all right if I
start with
like New Zealand is doing some beautiful stuff in this, and really what they've done is they've said, in a really clever approach, they've said, okay, let's go and do a systematic review of all of the actual true evidence that we have, and from that we will develop a list of things which all rental dwellings should have, and so that's actually made it in a lovely process through to now their new rules. So everyone has to do it. And, rental's a brilliant place to look at the quality of housing because, the average rental lease is about a year. So every year it's changing over. So it's like, your car registration or your New South Wales test on the quality of the vehicle, to continue that analogy.
Kate, anything on that? And then you, Chris.
Not really. I simply don't have a solution through the need to have government commitment, and I just keep getting stuck there. And I'm not saying that there's no resolve within government at all, because I do believe there is. But I think we've really shot ourselves in the foot with not having some of the necessary regulations and ways of checking, and I think possibly having a staged approach, starting with the rentals as the starting point, exactly, the practice, and going from there, or new housing. I don't know. It's I'd be interested to, given that I am a health person, I would be really interested in actually hearing from also members of the audience who may well be more housing focused as to some solutions there as well.
Excellent. Thank you. Chris?
Probably the only thought I have is that in anything related to sort of public health initiatives or to kind of preventative health initiatives is the length of time it takes to prove the value of something. Mm-hmm. And when we think about often policy cycles, political cycles, they're misaligned to that benefit. So with any kind of effort to create a registration scheme that is looking at providing value 30 years in time, I think that would be something that I'd lean back to, my peers here to say, do we have the body of evidence yet to be able to justify taking that action? Because I think absolutely it's a fantastic suggestion and idea, but with anything that kind of imposes cost today for deferred benefit tomorrow, I think we just need to make sure that we've got that that evidence there would be my practical comment to say make sure the evidence is there to make the argument. Yeah.
It is worth reflecting in both, of course, here in Victoria and New South Wales. We were literally watching what was happening in terms of the treatment of public housing towers and people's health outcomes related to that, both in terms of COVID, but also the restrictions that happened that caused people to miss out on what would otherwise be part of their normal health regime or healthcare system. Any comments about learnings, not just about COVID, I think we've touched on that, but the actual, for us, a big part of what we talk about is around social housing, concentration of people in particular areas. Again, any thoughts on the towers, learnings from what we would do differently next time when it comes to, say, concentrations of people in public housing and their health needs? Emma, or Chris, we'll start with you.
Yeah, so one of our biggest learnings is around determination. It's around allowing the community to be part of the response. So one of the biggest challenges in the lockdown was that it was imposed upon people and it wasn't done in partnership with community. And since then, all of the work that has been done has been facilitated by civic society, led by and delivered by community. And what we've found is that in recent lockdowns, the level of transmission of COVID has been below Victorian averages. The uptake of vaccine has been at Victorian averages, and in our most recent kind of wave in January, we again saw transmission at below Victorian averages. And that was because community led the response. Community, I mean, one of the things that we used to talk about in the early days of COVID was that there was a strong focus on community transmission of disease, but not community transmission of information. And so by allowing community to step into and own the solution, find solutions that were practical to their community context, their cultural context, that was able to negate some of the challenges of the built form. But ultimately, I think what needs to be reconsidered from a built form perspective is, are there naturally higher risk areas, and how can it be considered from the learnings of COVID that we make those areas lower risk? Because what we would then see is probably again, now that community are empowered to take the leads, if the infrastructure were aligned to that, we probably wouldn't find ourselves ever needing another hard lockdown like that. Yeah.
Excellent, true.
And I certainly, was going to echo exactly that. Community leadership is absolutely the key there. And the other element is it has given me hope in that we have seen the evidence of flexibility, we have seen the evidence of rapid change and commitment to that. So that actually gives me hope that that is completely possible.
Excellent. Emma.
Well, I want to make an observation that's a little bit different. When we looked at 15,000 Australians' experience and health and housing outcomes in COVID, and it's important to say that social housing tenants were protected in a way that we don't acknowledge. You know, the poorest social housing tenants compared to private renters, the poorest private renters, you get real insight into what's important about housing and the things that social housing gives that the private rental sector doesn't. And it's not just about housing, it's the wraparound, it's the security, it's not having to worry. So I think that's just a really important finding from that work.
I might extend on that a bit further and touches on one of the questions. So we in New South Wales, again, watched absolutely, and I was involved with the bureaucracy. Two things came to mind was 18 towers in all of New South Wales, most of them in Sydney, they're all fitted a similar criteria, shared lifts, shared access. So basically people's ability to be able to deal with COVID was compromised by the way in which they lived. That was the take home. Two things, is it true, and did it happen in Victoria or various areas, that the community housing sector, I certainly saw this, generally had an earlier handle and a bit better handle, using that word community. So community housing organisations or community housing providers seem to be able to get in and contact those community leaders or get in a bit earlier. And what I saw following that from was in New South Wales, DCJ, the Department of Communities and Justice, controls still 100,000 properties. They learnt very quickly what the community housing sector were doing, and they thought, we better do that. We don't want to see what's just happened in Victoria happen in New South Wales. So we were literally watching, 3 weeks behind. Any comments about community housing? And it's a bit of a theme that comes up sometimes. Friend or foe? Is community housing the answer to everything? Are we expecting too much of them? Is it the same rebadged how does community housing interface with health from your various perspectives?
Oh, look, I'll only add, imagine if we could put all of our tenures into a blender and pick out all the good bits.
Yeah.
Because, you know, in a way, they're distinct things, but, yeah, there's wonderful things about all of them. That's...
Okay.
One of the things that what I'd like to say is putting that health focus onto it is when you look at what happened with COVID and that when Aboriginal and Torres Strait Islander or Aboriginal community-controlled health organisations had the opportunity to lead, it worked brilliantly. And when government worked very closely with community organisations, it worked well. So I totally agree. There's the opportunity within community housing, providing there's the appropriate support and not the pressure that one size fits all. That there are no checks and balances or the checks and balances similarly aren't too onerous, so that it defeats the possibility of actually achieving the end result. But no, the community housing, there's certainly a lot of benefits there, but I think it has to be within the right support structures as well.
Good. Excellent, thank you. Chris, and you may not have any particular view on community housing, friend or foe, but it's this time of the day, it's worth asking.
Look, certainly I can't comment it from the housing perspective, and from the health perspective, I guess the only comment I can make is that they're a critical partner to us in guaranteeing and supporting better health outcomes, better life outcomes for a certain portion of the community. And possibly the only observation I would make during COVID is that where we have been able to work in partnership with community housing, where we've been given flexibility in terms of the ways in which we've been able to make localised models and responses in certain contexts, it has seen some pretty terrific outcomes for people. And so the only thing I would probably say from that is I would love to carry forward into the future the relationships, but also the flexibility and allocation of funding to support what's needed, not just to deliver the activities that we think we're there to do.
Thank you. A couple of specific questions. So one for you, actually, Chris, from another Chris. Do you know what is now happening with the HH program? I think sometimes we need not just CAOs or CEOs or COOs, but CAOs, Chief Acronyms Officer. Yeah. I'm not sure what a HH program is, but you might be able to enlighten us. Thanks, Chris.
So the Homelessness to Home program, it's so in terms of where is it headed to? Was that the question? Do I know where it's headed to? Look, from our perspective, we're a provider as part of a consortium, and what we understand at the moment is that there is some continued opportunity to keep providing through the community housing providers the head leases to the individuals that are housed under it, and we're continuing to participate for as long as we can. Our interest, though, is that the model gets seen as a new way of working into the future. So we would love to be able to carry forward what's been able to be achieved by having housing, social and health support providers funded as a collective in order to provide a collective response to residents. That probably doesn't answer your question, though.
It does. I don't know if I'm allowed to respond directly.
Yeah, please.
Thank you. The program is very good, and I believe it had great benefits. And I am part-time visitor, and I am on community activity group, and I do work with Star Health as a volunteer. And if assuming you're still there, I do know your CEO. I've met him many times. I was also on the online forum to actually help make decisions and set up the ideas that we wouldn't have another lockdown like we did in Flemington and North Melbourne. Right? I was one of about 10 residents from many estates across. We were the initial care community program in Melbourne. The one problem that's going now with the HH program is that unfortunately the department has a different attitude at the moment, local officers I'm talking about, in that they are now basically putting the people who, most of them off the street or wherever they were, very vulnerable, very bad situations, they're now being put into towers. They're now being put in places where they're going into high density, big problem areas, because of the actually part of Park Towers.
Yep. I might jump in if that's okay.
No,
So,
just saying,
yeah, no.
we're basically interviewing people coming in and hearing the problems.
Yeah. So I think the question itself, possibly what I'm hearing from you, and I don't work for STAR, so Damien's a colleague in the community health sector, but not a colleague in the organisation I work for. I'm happy to talk to you offline, because I think what you're saying is that you would love to be able to provide some feedback directly to the department as part of the program, and I can certainly support.
Doing that at the moment.
Yeah, great.
Excellent, thank you, and thanks for that. Another question. I'm interested in the panel about and thinking about whether there is a case to classify inadequate housing as a danger to health in a way that creates a legislative imperative to address. So, very much stick, not just carrot. What's the way? What would the panel think about the actual legislative punitive, or not punitive, but certainly backed up by legislation if it's not fair enough? Emma first, then Kate, then Chris.
Can I defer for a bit and have a think while the other
Yeah.
things
Absolutely.
That's a tricky one.
It is a tricky one. So how to create the legislative
Yes,
imperative?
It would seem that's the question. Absolutely. Yep.
It is, and I'm worried I'm going to be very cynical. When we look at how some legislation has been produced, there are a number of different elements that have influenced that production, and sometimes that is within the personal interest and commitment of the politicians who drive it. And I think getting that leverage is something that we can't ignore. And I think that is one of the key things that we would need to be doing is connecting effectively with those who are the legislators to create that shared desire.
Excellent. Chris, anything in the Emma?
The only thing I'm thinking about is probably from Kate's presentation in the recognition of there being potentially a rights-based approach that could be taken, and thinking about the SDGs as well for your Chief Acronym Officer. And just sort of starting to think about, could we, through those approaches, start to come up with some minimum expectations and standards? As to the process of legislation, I'm comfortable leaving that with other folks to think about. Yeah.
I suppose the obvious entry point for me is money and the tax system. So you can reward people for doing the right things if they're a mum and dad landlord.
Yeah, indeed. Yeah.
In the same way that you would reward an organisation for doing nice things. So in the whole spectrum of housing, there are easy bits to get at, and then we just work up from there. So social or community housing. There's a clear entry point for that. There's an obligation. The next level is probably, mum and dad landlords, and then we move up from there.
And you're right, just on that note, I having worked in aged care for a while and listening to one of the aged care commissioners, Briggs, there has to be a role for both carrot and stick. There has to be the opportunity where people are rewarded, incentivised, and you're right, that focuses on particular groups who enjoy. Others you need both, certainly need that. Just one point that keeps coming up, which is great, and I'd heard all of you mention it differently, the idea that somehow we rely on data, and it's, in a particular format, but photographs and images, and this idea that if we're talking about something to do with housing and the environmental, that a picture paints 1,000 words. I'm interested in that, and the extent to which, if a picture paints 1,000 words, I heard it yesterday here, then a site visit's about 1 million. This idea that somehow you don't ever get a full picture. We talked about it, the three of us, about we'd never met each other except for on Zoom, and how different people look when you meet them three-dimensionally. So I'm interested in saying, again, is that an element? Is that a part of being able to very quickly get to the nub of the problem here? When you compel people to respond to a site visit, very different things. Any thoughts on that idea of those three ways of looking at things?
I just think a problem doesn't exist if it's not visible.
Right. Yep.
And so, one of our big jobs is to make the invisible visible.
Yep.
And people don't ever see poor housing in, mainstream Australia, except maybe when their kids are students and they're studying, and it's okay to, it's acceptable. So, our big job is to show people. Every time we publish, I've said this story before, but often we'll publish, articles in The Conversation or something, and then they'll ring us up and say, oh, could you help? Because, all I can find is good, lovely housing pictures. I haven't got any bad ones. So, hopefully, the visuals really help tell that story.
And there's certainly instances of when the photos have been used in programs to expedite repairs and maintenance. So there's certainly evidence to show that the images are effective. And yeah.
Excellent. Chris, anything on that for you?
Yeah, the other part of that for me is recognising that, discrimination and stigmatisation is also a determinant of poor health. And I think by being able to change the public narrative around poor housing as well, is that there is an unfortunate narrative across the Australian context that poor housing in some way is reflective of its occupier. And I think it would be really wonderful for us to start challenging that and start pushing that narrative back to the responsibility on those who own or manage the property rather than those who occupy the property.
Very good. We've talked a little bit about the towers, so I've touched on, and I think we're aware that, Chris, from your point of view, that the towers are not a number of issues with the lack of gas supply, lower ceilings. There's lots of problems, so you can't even have a ceiling fan. So we recognise that a lot of the things that we can do moving forward are great, but retrofitting and retrospective is a much bigger deal. And when we talk about housing, turned over 1%, if we're lucky, 2% every year. The challenge is really existing properties as well as moving forward. One question that's come up, and it's absolutely right. We talk about government. We talk about the term interchangeably, but really, we could talk about the federal government, tax, the state government when it comes to settings, but what's the role of local government in monitoring quality of housing, given the variability that we have across climates and across areas? Just interested in the three of you, thoughts on local government and the role of that. Start with you, Chris.
Yeah, in terms of monitoring, look, I think that's always a challenge of adding, in a rate-capped environment when there's already sort of stretch upon local governments to think about what services they're capable of providing and not providing. But what I'd probably extend it to saying from a health perspective is that local governments do have a role in municipal health and wellbeing and planning. And so what's the opportunity for them to start contributing to the thinking about place and space? And Kate made reference to, it might have been Emma, but about green open space, being part of good housing and the ability for local government to think about how town planning and how the way in which they're contributing to municipal health and wellbeing more generally. I'd probably focus on that as a starting point. Yep.
Yeah, good. Sorry.
And I totally agree. The planning processes are certainly something that local, from a local perspective, and ensuring that there is that they prioritise climate and the impact of climate in their planning as well, and livability. I think there's lots of, and I know that a lot of councils are moving towards that, but there's lots of scope there from that perspective.
Excellent. Emma.
I might pass it back.
That's good. Look, on that one, it's interesting because, again, we work for Shelter, we advocate. You'd be surprised that even now that we're getting inclusionary zoning or council planning schemes compelling developers to provide X number of affordable housing units, that's affordable. It doesn't mean that the amenity, and in fact we need to make sure, and there's a number of councils in New South Wales elect to do this, but there's no real compunction on them to make sure that the 9 affordable or the 9% or whatever the affordable housing delivery has the same amenity as the rest of the units. So again, I've learnt so much today hearing about the intersection of health, the environment and the design. It might be affordable, but the amenity is pretty ordinary, so that's good. All right, look, we've just got, I think, one more question. I think we've already touched on it, but really it might be a concept that we've touched on, but science photos. I think there was an anonymous question we had saying, do citizen science photos give a fair indication of rental housing conditions? If there are any limited photos submitted, and is it more likely that we're going to get poor, unhealthy conditions submitted? I'm not sure what that means, but have we touched on that, do you think, Emma?
Oh, look, I mean, that's a perfectly fair comment. They're pictures of housing problems. Right. So we haven't asked them to send their pictures of the beautiful new construction. But it's a database of housing problems, effectively. The cool thing about that whole process was that people were able to leave a little comment on the bottom, right, and you get this wonderful context about, I've been asking my landlord for 12 years to fix this, or, when I moved in, it looked white, but it turned out they just painted over the mould. Those stories are wonderful. But you're absolutely right. It's not a representative database of Australian housing. It's poor.
Excellent. Any other comments on that?
It's probably not an answer to the question, but rather to note that that in the work that we did in response to the towers, it resulted in us employing 300 people who lived in the high-rise context.
Yes.
And so those individuals who we referred to as health concierges or bicultural workers, not only did they bring the experience that we required professionally for them to take on that role, but they brought the local context and the cultural kind of knowledge as well. And so we were able to utilise them in a similar way, I guess, as sort of citizen scientists, because they were able to work within the community, speak to the community, capture data on behalf of community. And again, that fed into the self-determination piece around the ability for them to own the solutions as well. So whilst it's not necessarily answering the question about the specific question, I think you cannot discount the value of citizen scientists in capturing good data and the ability to get a rapport quicker, which gets better data quicker.
Excellent, very good. Two questions. One's more of a statement, and I think we'd agree with this. Basically, it's that government has a lot to answer when it comes to housing health. Years of neglect targeted at properties and areas, and then handing them over to the CHPs to deal with. So certainly kicking that up the line. When we know already there's so much data about the life of a building, year 7, year 15, year 21, year 40, there's well-established patterns of how expensive it is and what good maintenance looks like. It shouldn't be a mystery. The last question I think we might leave on is Anne Donovan, who's submitted a question suggesting that we do need to, if we're going to go to these certified, certain areas and measurability of various things, that we do need to absolutely recognise the regionalised guidelines due to the temperature variability and differences across Victoria regions, and indeed I'd say not just Metro Victoria and regional, across all of Australia. And I know that a couple of years ago I was in Sydney working 47 degrees at Penrith. I think at the time it was the highest recorded temperature on the planet. 47.9, something like that, extraordinary, and people were working, living in these conditions. And I know the temperature was taken in an aged care facility, had no air conditioning, all the way through to what we know is increasingly the variability in some very cold conditions. So I think that's probably an important thing to know. Look, just finally, any final comments for the audience, any reflections that you have? Very quickly, Emma, then Kate, then Chris. Any final learnings, things that you'd like to wrap up with, or some take-homes that we could leave today's session with? Emma.
Okay, I think if I could leave anyone with a take-home about housing conditions, it's probably that to keep in mind that it's often the people with the worst health who have the worst housing.
Kate.
And for me, I think it's really taking what Chris was saying in the people who are living in social housing are not the reason for the poor housing condition, and ensuring that any hint of that narrative is removed, I think, is essential.
And given Kate's stolen my my comment, I think probably the thing I'm reflecting on now is that local context is important.
Yes.
We can think about standards and nationalised approaches, but even that final comment that was made about there being need for regional approaches, if we think in the local government context, the heat island effect in certain suburbs relative to others because of the natural vegetation, like this really has to be something where we find ways to engage locally, think locally and act locally.
Excellent. A very good note to end on. Look, on behalf of the whole people attending this session, I'd like you to join with me in thanking Chris, Kate and Emma for an extraordinary session, and certainly one that I've learnt lots of. Thank you all three. All right. Thanks, guys.